So welcome everyone. As you come on, find the chat please and say hello and where you're coming from and what your concerns are about LP little a or any of the other cholesterol issues you might be dealing with. We are really excited tonight to get going with our program. And so we'll just wait a few minutes before we start our slides. I'm Susan Ward. I'm a national board certified health and wellness coach, and I'm here in my capacity as a Family Heart Ambassador to host this wonderful Empower LPA meeting series, which we've been doing for almost 2 years now. This is we're into our second year. So we're very excited about being able to share our knowledge, and the knowledge keeps growing. So there's no going back. We have to keep going forward. And so any questions that you have during this presentation, we'd love for you to put them in the chat as well. But if you put them in the Q&A, we will find them. And so tonight I have helping me with this presentation a Family Heart Foundation employee, Misty Votaw, who is an associate for the outreach. And I do also have another guest here who I've been dying to have on our series, who is Ann Dodge. She's at the bottom of the pile there, but Ann is an RN, a nurse practitioner who is really fabulous. And when we have had training for our ambassador program every year, I'm always amazed at her wealth of knowledge and her compassion. And so I'm so glad to see her here because I've been dying to have her on one of our calls. And we also have two other really wonderful care navigators from the Family Heart Foundation who I will introduce in a minute or so. But as we get going here, and I can advance my screen, again, this is the Family Heart Foundation Empower LPA meeting. And tonight our topic is your LPA compass, LPA standing for lipoprotein little a, guidance from Family Heart Foundation's Care Navigation team. And our speakers tonight are going to be Aurora Sullivan, who has a Master in Public Health, and she is a community and care navigator, and Miranda Schartz, who is a bilingual care navigator, being an expert in Spanish. And as I said, we do have Ann Dodge here who will be helping us with answering some of the questions as we go forward. Just a moment to thank our sponsors. We always want to acknowledge the generous support of the sponsors for I should have 2026 in here. I didn't catch that one, Community Activation Program. And as the Community Activation Program is sponsored by Lilly and Novartis. So a little medical disclaimer here, today's program is really for informational and educational purposes. The content is not designed to be a substitute for professional advice, diagnosis, or treatment, nor does your participation constitute a medical or coaching relationship with the presenters or the employees or officers of the Family Heart Foundation. Future research may impact today's presentation. Information is constantly being updated and changed, and so be on the lookout for the fact that what's true today may be different tomorrow. Do follow up with your medical professional for specific recommendations that pertain to your or your family member's diagnosis or treatment. And please remember that tonight's call, we're featuring our Family Heart Foundation Care Navigation Specialist, and you are welcome to reach out to any of them at any time when you need more help or assistance or guidance to find resources for yourself. So again, tonight I want to introduce our special featured guests. Aurora Sullivan has a Master in Public Health, and she is currently a public health professional working at the Family Heart Foundation. And she is in the Care Navigation program, and she works with people who have familial hypercholesterolemia, which is 1 in 250 people, and elevated lipoprotein little a, which is 1 in 5 people globally. As a public health worker, her mission is to advance health equity for all populations. And she has a degree that focuses as such, and she's ready to put her interest to good use in the workforce in order to address and minimize health disparities in all communities. She has been a former community outreach worker for Reach Up, and she has been an adjunct professor of public health at Stetson University. She's also an OPS educator from the Florida Department of Health. And as I said earlier, she has a Master of Public Health from Bethune-Cookman University and a Bachelor of Arts from Stetson University. Our other guest speaker is Miranda Schartz, who is a bilingual care navigator. She has focused on care management and case management as a lead with Piedmont Health Services before coming to the Family Heart Foundation less than a year ago. She had been an outreach worker with the Pender County Health Department, and she has her Bachelor of Arts from Duke University in both Spanish language and literature. And as a care navigator and being bilingual in English and Spanish, she is really here to support ongoing efforts to expand services to a broader community. Her background in case management and health education really serves her to work with individuals and families who are living with myriad chronic health conditions and understanding both the complex physical and emotional impacts that accompany chronic disease management. Miranda enjoys meeting people from all backgrounds through the care navigation team and hopes to meet others on the call as well, as I know all of us do want to support you with all of your questions. So with that, I'm going to stop sharing my screen and let these care navigators get going with their presentation.
Great, thank you so much, Susan. Here, let me share my screen. Okay, can everyone see my screen?
Yes.
Okay. Sorry, it's showing up oddly on my end for some reason. All right, back to the beginning we go. Okay, so welcome to our Care Navigation Center. As Susan mentioned so nicely, me, Miranda, and Anne are the care navigators that are on the call, and I will give a little bit more information about us as we get started. So let's start with an overview of who we are and the basics of what we do. So we're here to help people in many different ways. People may utilize us in every step of their journey, as you can see listed here. So that's anything from first learning what even is lipoprotein A to becoming a family heart ambassador. So we provide support and resources to help people feel informed and empowered while navigating these chronic genetic conditions. And here is our Care Navigation Center team. Ann Dodge, our senior care navigator, is an RN and nurse practitioner with an extensive background in pediatric lipidology. I'm Aurora Sullivan. I'm a community and care navigator here, which means I work in both care navigation and our community engagement team with Misty Vota. And my background is in public health. We also have our first bilingual care navigator on the team, Miranda Schartz, who has a background in social work. Miranda and I will be speaking today, but like Susan said, Anne is here to join us for the Q&A and also provide support with any other questions in the chat. So why come to us? Why use care navigation? We have a bunch of tools and resources. We have infographics and webinars and brochures that tell you all you need to know, right? But at Care Navigation, we also provide you with that information that can help you understand your diagnosis, find a doctor, get your family screened, and more. We're also your team members. We're here to provide you with the knowledge that makes you feel empowered about taking the next step. We're here to provide individualized support every single step of the way, whether that's through call, text, or email, and we will equip you with information on how to advocate for your health to receive treatment and care that you prefer. One user of our care navigation services expressed their gratitude for our program, expressing that it was the most informative, actionable, and anxiety-reducing plan that they'd gotten in their 3 years since being diagnosed with high LPA. And I know that a lot of you probably feel the same way just from having the care navigation calls that I do daily. So, how do you find us? To contact us and schedule your own care navigation call, you can go to the Living With tab at the top of our homepage. Under Support, you're going to click Care Navigation Center, and it'll bring you to this screen where you can click the button to contact us. You can also use the email address and phone number listed on the side panel to contact us and receive a link to schedule a call. So I'd like to go a little bit more in depth about each service we provide. First and foremost, we're here to help you understand what those lipid panel results actually mean. In care navigation, we will focus mainly on LDL and lipoprotein little a. LDL, or low density lipoprotein, is what is also known as that bad cholesterol. A high LDL level leads to a buildup of cholesterol in your arteries that can lead to cardiovascular disease and increased risk of heart attack and stroke. Lipoprotein A, or LP little a, is an LDL-like particle that is an important indicator for risk of cardiovascular disease due to this LDL-like structure and extra apolipoprotein factors. So on the lipid panel that we have here, the sample, you can see the LDL level and the lipoprotein A level that the arrows are pointing to. And so why do we focus specifically on LDL and LP little a? Our roots are in genetic dyslipidemias. LDL is an important factor for every individual to know, but it's also an indicator for FH, or familial hypercholesterolemia, which has always been a focus for us since we were founded in 2011. FH was at the forefront of the scope of our work for many years as the FH Foundation, and now as the Family Heart Foundation, we hold true to that focus on genetic dyslipidemias, with lipoprotein A included. So we're here to help you from the very beginning of your journey, and that includes understanding what lipoprotein A is and what that diagnosis means. As we stated, lipoprotein A is built very similarly to LDL and has similar plaque building properties. Because of this, high lipoprotein A levels are associated with higher risk for heart disease and stroke. LPA levels are completely genetic and will not go down or up with lifestyle factors. According to the American Heart Association and the American College of Cardiology, lipoprotein a levels are high if greater than 125 nanomoles per liter or 50 milligrams per deciliter. For many individuals with genetic dyslipidemias, we recommend finding a doctor that has knowledge of how to monitor and treat conditions such as FH and high LPA. Our specialist map contains over 630 specialists worldwide that we have vetted on their ability to help individuals with these conditions. Specialists can be lipidologists, cardiologists, endocrinologists, or other care professionals who are experienced in this kind of work. You can also use our specialist map yourself by going to this link on our website and searching for your location. We suggest going by zip code. Regarding treatment options, there is so much that you can do to reduce risk when you have high lipoprotein A. Although there are currently no approved medications to lower lipoprotein A alone, some are in the last stages of clinical trials, and we hope to see them on the market soon. The only currently approved therapy for lowering lipoprotein A is lipoprotein apheresis. This treatment is for individuals with both severe FH and high lipoprotein A levels. If you believe you could be eligible and would like to learn more, please don't hesitate to reach out to us for more information. Generally, though, lowering LDL is the first course of action for an individual with high LPA, as this can help to decrease cardiovascular risk. Managing comorbidities and lifestyle factors such as diet and exercise are also important. Care navigation remains completely therapy agnostic, so we're never going to push you towards any sort of treatment. We're simply going to give you the information and help you identify the best tools in your toolbox for your own care. We're also here to help you connect with others in our wonderful community. We have two online support groups that we monitor and maintain, one for FH and one for lipoprotein A. These groups provide a space for individuals to have positive and productive discussions about living with these conditions. There are also many Family Heart ambassadors floating around in there as well that can help provide support. And here at the Family Heart Foundation, we love to engage our community in many different ways. So if Facebook is not your thing, we also invite you to become a Family Heart ambassador, join our webinars, or share your personal story. We also have LPA Awareness Day coming up on March 24th. So please stay connected with us via newsletter or social media to learn more about that campaign as that gets closer. And we can also help navigate cost of care and some insurance bumps. So our Navigating Insurance Guide is a resource that we're able to provide that can assist with barriers and provide more information on insurance terms, accessing treatments, and other options. So care navigators can help provide more individualized support regarding topics such as medication discount cards and copay assistant programs, but we can also give you this guide and send it to you so that you're able to go through and find any information that you might need for your particular case. And for individuals who are interested in getting involved in clinical trials or just want to stay up to date on them, Family Heart Foundation has a webpage that allows you to search for active trials. To use this program, you can simply search for all lipoprotein A trials, and you can find status, start date, locations, and more. And I do have that link on the bottom of the screen there as well. And now I'll turn it over to Miranda.
Thanks, Aurora. So next, I'm going to talk a little bit about family screening, basically what it is and some of the ways that Family Heart can support you in making sure that your family is also protected from heart disease as well. So when we talk about genetic lipid conditions like high Lp(a), it's really crucial to understand not just the individual's risk, but that family risk as well. One of the things that we talk about at Family Heart Foundation is that when you find an individual living with either FH or high Lp(a), you're really not finding just the individual. You're uncovering a family living with these genetic lipid conditions. So if you've been diagnosed with high Lp(a) or somebody else in your family has been diagnosed with high Lp(a), we know that others in your family are at risk as well. And we can't rule out that risk until testing is completed, until each individual risk has been screened for their lipids, including the lipoprotein a as well. You'll see many people in our community who come to us in kind of the picture of health state, right? So individuals who are athletes who have been vegan for decades that are really surprised and caught off guard by their high Lp(a). And as Aurora mentioned earlier, that is because it's a separate factor than what we may consider typically putting at people for high risk with their cholesterol. As we think about genetic disorders in general, sometimes genetic disorders don't show up until later in life. But with cholesterol disorders, including lipoprotein a, we see these happen, these start to show up sometimes in children, oftentimes in children. But certainly by early adulthood, we can start screening for lipoprotein A. It's not something that we need to wait until individuals are in their 40s, 50s, beyond to figure out if they have high Lp(a). It can be done much sooner than that and really is recommended for those younger adults. That the earlier they know that they might be at risk for heart disease, the sooner they can really take some action to reduce that risk as much as possible. So we recommend certainly everybody get tested once in a lifetime. There may be nuances around when children get tested for the lipoprotein A. If there's questions, if anybody has questions about pediatric testing, Anne can help address some of those as well in our Q&A. One thing I wanted to point out with this pedigree on the screen that we're looking at, we really just want to highlight that for any one individual living with high Lp(a), if you have children, there is a 50-50 shot for each child that they will inherit high LP little a as well. That means that not every child will necessarily have it. They could have it, they could not have it. But again, just going back to that point that until an individual is screened, there's really no way to know whether they do or don't have high LP little a. And really just broadly, we should be screening anyways. High LP little a is incredibly common. About 1 in 5 individuals in the general population are living with high LP little a. So, I always encourage people, hey, outside of your family too, let's get neighbors, friends, colleagues screened as well in this process. All right, so let's talk on the next slide about how to get screened. So we offer a really cool program through Family Heart directly for individuals who are 18 years and older in the US that will help screen for basic cholesterol as well as the lipoprotein A, which can be really hard to get. That Lp(a) test, we find many individuals who are trying to access it, whether it be through primary care, sometimes even specialty care, that have not been able to successfully advocate to get that test done. So we offer the ability to do this, and one of the best parts, I think, of this program is that this can be done at home, the entire process from beginning to end without needing to leave the comfort of your home. So for family members who may be at risk but have a little bit of hesitancy or have some difficulties getting tested through traditional channels, this at-home cholesterol connect screening kit is a really valuable resource to be able to have that kind of just baseline of where are my cholesterol levels at, and am I affected by high Lp(a). This kit is done at home with a really simple finger prick and a few drops of blood, and that's all it takes to understand if somebody could be affected by genetic cholesterol disorders like Lp(a) or FH if looking at the really high LDL cholesterol. The screening does not look at the genetic material in and of itself, though. It is giving back those basic lipids like you would expect to see on a lipid panel coming from a doctor's office, with the addition of that lipoprotein A included as well. And kind of the beauty of this whole circular process is if somebody does this Cholesterol Connect screening program at home, gets their results back and really wants to talk about those results or needs help understanding what those results mean for them, they can come back to Care Navigation, or maybe it's their first time coming into Care Navigation. We'll help them understand those results and what are some next steps that they can do with those results as well. The service, this Cholesterol Connect program, is offered in both English and Spanish as well. So for Spanish users, we have a website set up that they can order the kit in Spanish. They'll receive the kit with its instructions in Spanish and results as well in Spanish. And then, of course, if they do opt to come to Care Navigation, I would work with them to go over those results and next steps as well. And speaking of Spanish services, we'll go to the next slide. So, as has been mentioned a few times, I was brought on early last year as our first bilingual care navigator for English and Spanish. So, any of our care navigation resources, essentially through the calls, we are able to now provide those in English and Spanish as well. We can offer services through other languages as well via the use of interpretation services. I only speak those 2 languages for now, though, so that's what I got to stick with if it's just me. Otherwise, we will get an interpreter on the call, though, for individuals who may have different language preferences. So like I mentioned a moment ago, when folks want to do this Cholesterol Connect program, that process is also entirely available in Spanish, from the ordering to doing the kit at home and then getting support services after that step. We're also actively working to update some of the infographics that we've created about cholesterol disorders, including lipoprotein A, as well as FH and just general high cholesterol concerns. Many of those we have in English, and if you haven't seen those before, we'll show you where to check those out. We're also actively working to get those translated so that they're available for broader communities as well. Okay, go to the next slide. All right, so there's many individuals that come to us every year, and each case can look quite different. Every need we try to meet uniquely. So when folks come into care navigation, we really are trying to be person-centered and provide the service that that individual in front of us needs at that time and that their family is looking for. So I'm going to go over just a couple of brief examples of what care navigation has looked like for a couple of users, but again, can look very different depending on what the individual need is. So for our first case, so to speak, we had a young woman in her 30s come to here. She had spent most of her life focusing on a sibling that had heart disease, and be the kind of the family's fun to think about her own health and some of these preventive measures that we would encourage. She hadn't really been able to do that from focusing and caregiving for her brother. So she started proactively looking at her own health a couple of years ago and found out that she lives with high Lp(a) and that her LDL also puts her at an increased risk for developing heart disease. She had had an appointment with a cardiologist before she came to the Family Heart Foundation, and felt very dismissed by that interaction with the cardiologist. So she decided to come to Family Heart because she was trying to figure out if her concern was really warranted about her results and how to really move forward from there. So in care navigation, we validated her concerns about her health and acknowledged that she has not only the right to be advocating for herself, but that really is what's recommended if you're living with high Lp(a). We know that that's a risk factor to increase risk for heart disease, and so we would want her to pursue further care. So we helped find her a specialist. She connected with a specialist via our map. She came back to care navigation to prep for that visit. After the visit, she emailed us back to let us know how it went. Had a really great interaction with that new specialist, felt heard, felt supported, and like she was actually getting some action. She was also armed with a more aggressive plan to help treat her dyslipidemias. And she continues to be in touch with us about her care and to update us on kind of the steps going forward. And she's going to hopefully become an ambassador with us. All right, we can go to the next call. All right, and then just one other quick example. So we had another individual, a 50-year-old woman who came to us principally through our Cholesterol Connect program and found out that her Lp(a) via our screening kit was above 240 nanomoles per liter, and her LDL-C was also in the 180s. So both very high levels. Her primary care doctor had seen those results when she shared it with him, and he chose not to prescribe any therapy, didn't seem very concerned for the outcome of those screening results. So she came to care navigation. We helped her find a specialist. She got started on a statin treatment and had already seen her LDL cholesterol drop by 70 points when she followed up with us. She was planning to continue on that statin therapy and is also considering secondary therapies alongside that specialist. And because she has an adult daughter, we also talked about the risk for her adult daughter having inherited high Lp(a) and potentially other cholesterol disorders as well, and how to get screened for her daughter as well. So as you can see through both of these cases, somewhat different outcomes, different needs, just depending on the individual. So some individuals will choose to come back to care navigation repeatedly as they go through their cholesterol kind of treatment journey. Others may connect with care navigation one time and then choose to kind of tap into some of those Family Heart resources that we have in different corners of the organization as they go through their cholesterol management process. All right, so next we're going to talk about some of those other resources that the foundation offers that kind of support and supplement what we do in care navigation as well. So on our website at familyheart.org/resources, you can see some of these infographics that we have created to help support you as an individual living with the conditions. This can be really useful just as a quick quick guides, quick glances at these different dyslipidemias. So these here that we have displayed are for lipoprotein A specifically. These can also be really helpful when we're talking about family screening and wanting to share the importance of screening for these conditions with family members, or again, colleagues, neighbors, friends, whomever may need to be screened. So these are all available for download and printing, or emailing, however you want to share that with folks in your communities. Go to the next one. And then all of you have made it here this evening, so I'll assume that somehow you know how to get to our webinars. But for future, just quick reference, that you can find a historical archive of our webinars at familyheart.org/webinars, and can also register for upcoming webinars as well. So if you weren't able to attend a past webinar that you were interested in, check that out. You may be able to find the recording, or should be able to find the recording there. And then for upcoming webinars, both for Lp(a) and FH, you'll find the registration link there. And as I say as well, if you're not diagnosed with either of these conditions, or not yet, or questioning if you may have and are interested, these are open to the public, the community. So feel free to join any webinar that looks of interest to you. We'll go to the next slide. All right, so care navigators in action. When we're not in the computer screen, we do like to get out and about in the wild and get out into our communities. So on the left, you'll see us in action at a professional event where we often go throughout the year to share about these genetic dyslipidemias, even with physicians, nurse practitioners, physician's assistants, really health professionals that may not have a lot of knowledge about these conditions as well. So we go out and help them get screened, because many of them also do not know their cholesterol levels. So we help them get screened, as well as share education information to help empower them when they're in the exam room, and to equip them with the tools and knowledge that they need to know to effectively work with their patients. Then we also love going out into community events, whether that's back to school events or health fairs, or recently we were at a senior center to also talk about high lipoprotein A and FH, and share screening opportunities. And when we get the chance, we also do screening with our little finger pricks in the community, so people can get screened right then and there. Next slide. There's some more of us in action, so we're kind of all over the place. And then we can go on to the next one. And then I'll talk briefly about some other kind of functions that we support from care navigation outside of the one-on-one calls that we do with our individuals. So like I mentioned earlier, we put together some kind of educational materials that can be used by the individual at any point, whether it's during a call or not. So Anne, who's on the call with us, Ann Dodge, has done a really wonderful job of compiling a lot of the educational content that you'll find in these infographics, and our communication team puts together these super eye-catching and really useful graphics to make this content stand out. So encourage you all to go check it out. The CT calcium score one's relatively new. The cardiac testing one is pretty new. And then hot off the press is the peripheral artery disease one. Most of these, if not all, are accompanied also by a blog post to give a little bit more depth to the content. And then these 1 or 2 pagers are really easy to download and keep on hand for reference. But I would highly encourage you to check out that information. Our next one. And last but not least, Aurora mentioned earlier our family heart specialist map a little bit, and we have talked about it throughout the call. So our specialist map is one of the most requested services from Care Navigation, and for good reason. We understand that when folks find out about their high Lp(a) or high cholesterol, you really want to get connected in with the right team that knows what these disorders are and are going to be able to feel out the nuances and help you get to those next steps of treatment. So our specialist map, we focus on adding in specialists who have a deeper knowledge of these genetic dyslipidemias, the FH and high Lp(a). We help kind of do this process manually. So alongside our ambassadors, care navigators also help keep this kind of process of the specialist map running. It is a manual process and it comes pretty organically. So when we know of new specialists who are, come on our radar or maybe new to practicing, we will do a vetting process to make sure that they really have a solid foundation in genetic lipid disorders, and then we will add them to the map. So that being said, if any of y'all are working with a really great team and you don't find them on our map, please let us know so we can do some vetting and get them added as well. All right. Yeah, so that's the end of our presentation. I really appreciate everybody here joining in this evening, and would love to meet any of you, whether it's the first time or meet you again through Care Navigation when you get the chance.
Thank you so much, Miranda and Aurora. That was wonderful. I really feel that you covered a lot of territory. You did it very, very succinctly, and it's amazing what the Care Navigation team does, considering that there were just three of you. It's really quite a feat. So my thanks to you, because you've done a great job. And let's get on with some of the questions that we have. And if Anne would like to come on or Misty would like to come on, please feel free. And we'll start going through. I think we do have some in the. I don't know if we have in the Q&A, we have a few. Why don't we do those first? Because there's a few of them. So I think the first one here has to, I think there's, has to do with statins reduce LDL, but I feel the focus is on reducing large, fluffy, safer LDL. Also, statins may increase Lp(a) and can increase A1C. I find these factors aren't factored in for taking the statin. After a year, my Lp(a) has increased a third to 198. You don't mention here whether that, I'm assuming that's nanomoles per liter, but we'll see if you added that below. I now am taking the statin every other day and will retest next month to see if the Lp(a) has settled down. Not sure what to do, but if it hasn't, except to really focus on whole food, plant-based diets, reduce LDL and other lipids, and stop the statin. Any other info to add, please? I think that there's a lot to unpack in that question, but we actually did some pretty hefty seminars on these topics, or webinars in the last few months. And if you do look them up, I know that Dr. Kira did a whole thing on the addressing the A1C and the issues that are associated with that. Okay, so who would like to handle this question? Anne, do you want to handle that one?
Yeah, I'm happy to address that. And that's a very common question that we get. And it is true that statins can increase the A1C, and statins can also increase the LPA by 5 to 10%. And there was another question about that in the chat as well. So I'll try to address both at the same time. But what we have to remember is what the protective, and first I have to preface all of this by saying whatever I'm telling you is not direct medical advice. I am a nurse practitioner, but I can talk to you about guidelines and what is recommended based on the research that we have. And so with the statins increasing LPA by 5 to 10%, which doesn't always happen, but you have to remember that LPA normally fluctuates by 20% from one reading to another, which is a very big amount, right? So if your LPA is 300, it could be varying by 60 just from getting it checked from one time to another time. Also, it can change based on different states of what your health or your life is going through. With women, it can increase by 20%. With infections, with COVID, with the flu, with other things, it can increase quite a bit. And so that's why we normally only recommend someone get their LPA checked one time. All we're trying to do is put you in the category of elevated or normal. Otherwise, there's going to be many fluctuations, including medications, illness, menopause, pregnancy, breastfeeding, that we know are going to happen, but we still want to control for the one risk factor, which is an elevated LPA. We don't care if it's 300 or 400, and we don't want you to care about that either. We need to address the risk factor that you have right now of your elevated LPA in the face of all of your other cardiac risk factors, which the most important one would be your LDL. So to decrease your statin in the face of this would be a contradiction to what is recommended, because we know that the lower the LDL, this is bottom line, it's a linear risk. The lower the LDL, the lower the cardiac risk. So to back off on your statin, even though your LPA may be increasing a little bit for who knows what reason, you're hurting yourself on the other end. Because I look at LDL and LPA as two little naughty boys in a classroom. And when they're in there together and aggravating each other, and they're creating the inside of your arteries into kind of a hostile environment, you need to get them both under the best control you have. Right now, we don't have medications to lower LPA, so it's imperative that we get your LDL to the lowest goal that you need for your risk factors. Does that help?
I think that's a really good answer, Anne, because it covers a lot of territory. And again, for those of you that are concerned about A1C or something like that, I really recommend you go and look up Dr. Amit Kira's address to our group, and that was in June of this year. So that's probably on the YouTube channel for the Family Heart Foundation. We specifically asked him to address that issue because there are some other medications like Repatha that people have had that response to. And a lot of times, and correct me if I'm wrong, but I really do think that sometimes genetics plays a role in what's going on with our response to medication. And we do know that there's a whole field of pharmacogenomics that really looks at that whole aspect. So the real thing that Anne is focusing on is what is the greater good that's being done here for you with the medication. And you can always go back to your physician and really bring that up and see whether there are other things you can experiment with. And many people do that before they find the exact recipe that helps them.
Right. And then the question to the fluffy LDL, I know there's different tests for checking the sizes of the different particles, but one thing we cannot control is the size of your particles. We do know how to control your LDL. And so that is what we need to focus on. And just remember that the statins do three things, very important things in the face of an elevated LPA. And that's that they reduce inflammation from both the LPA and the LDL. And there's significant inflammation from both of those that create atherosclerosis. They reduce the soft plaque that is forming from both of them, and they stabilize the soft plaque that's formulating from both of them. And you can't see those three effects in the numbers that you're measuring in the labs. So we really need to focus on the positive effects that the statins are having.
Thank you. Let me see if I can get into the chat now to see if there are other questions here. So I think we covered most of them. If I missed you in the Q&A, I'll come back and find you again.
I think there was a question around testing in children.
Oh, there is
about
somebody here who
Repatha.
there's somebody here who has a 6-year-old, and I don't know if you saw that, Anne, but there is also a question about testing children and treating children, and if you would address that with LPA, that would be great.
And
And
there
for
was a
testing
specific
LPA
question
or
around
lipids, for testing lipids or LPA in general.
I'm trying to find the
There was a
exact.
question. I have another question for Anne. What are your thoughts on a child taking Repatha for lowering Lp(a)? That's the one that I
Okay,
saw.
that's the one you were talking about. Okay, and
There
yeah.
might be.
So, so Repatha is approved in children for lowering LDL and for FH. It is not approved in anybody for lowering LPA. It was not designed in that. It was not tested for that. That is simply a nice side effect that we've seen in many people is that it lowers LPA by up to 20%. We know it lowers the number. However, there's never been any outcome data on whether that number lowering of 20% translates to a reduction in heart disease. That is what the current trials are doing right now in phase 4. And so we will have the answer to that soon. So there is no indication for a child to be on Repatha to lower LPA. If they have FH and their LDL is not under control with our normal therapy of statins and Zetia, then yes, a Repatha would be indicated in that case for a child.
So let me go back to the one that was before that in the beginning. This individual has a 6 year, I think it's an 8-year-old, I'm sorry. And she has FH and high LP little a, and she just got a stent at age 39, and she's taking this time to learn as much as possible for her future health and to be on top of her son's health. Can you give some advice there?
Yeah,
Or
I can. And for some reason, I think I was answering some questions, but I think I answered them live, so they disappeared quickly. So I'll repeat that answer to everyone. And so I think she was mentioning the one child had FH and high LPA, and the other child's LDL was normal. And should she still be concerned about his LPA? And my answer to that is get him checked. I mean, it doesn't hurt to have him checked. You know, it runs in your family. And then we can follow that risk factor over the course of his life. If he becomes an adult and his LDL is over the normal of 100 and he has a high LPA, then there could be a discussion about statins to get his LDL to a lower level due to his extra risk factor of high LPA. But we won't know that till he gets it checked. So it's completely reasonable to have that checked. And feel free, like they mentioned, I have a pediatric background in lipids and LPA, so I'm happy to give out in the chat my link for any of you who have specific pediatric questions. I can give out my scheduling link and schedule an independent, free of charge Zoom call with you about your children.
yeah, some of these are going back and forth, and I'm trying to find, I'm not sure there's a question here. But I think there was a person they were changed from atorvastatin to rosuvastatin and then changed back and is having another blood test in a month. I don't know what the question is there, but it sounds like there's a question. So
Yeah,
trying
I think I was addressing a little of that during the call. I think she had some varying LPA levels, and I wanted to address which I did the different reasons for that. Switching
Mhm.
to a different, there's no reason to switch to a different statin just to see if it's going to lower or higher your LPA more. The only reason to switch to a different statin is if you're having side effects or if they think that the stronger statin would help you more get to goal.
Mhm. Um,
I see a question here in the Q&A. What do you recommend for someone who has aortic stenosis from very high LPA and wants to avoid repeat of this following aortic valve replacement?
Okay, so it sounds like it was severe enough. They already needed their aortic valve replaced. So
Mhm.
that new valve has got a pretty good life on it. So that's great. And the other thing, the most important thing is to have good follow up with your cardiologist and have very regular echocardiograms, and that interval will be decided by your cardiologist, because with the new valve you probably have no aortic stenosis, but with a very high LPA, aortic stenosis can develop sometimes quickly, sometimes unpredictably. Usually it's a slower linear path. So at a minimum, yearly echocardiograms, and they can completely quantitatively measure any new or developing aortic stenosis that you're getting, and they will know exactly when to intervene again. So this should never be a surprise to you or an unexpected consequence.
Okay, I have one here. If I could get my LDL down below 70 with statins, why would I also add Repatha?
Well, that would depend if your cardiologist is recommending that and if for what reasons. So, if they're recommending that because you've already had some sort of a cardiac event, an extremely high calcium score, a very high LPA level, a very, very early family history of heart disease, history of smoking, many, many other cardiac risk factors. There's many reasons, important reasons, why your cardiologist would want your your LDL below 55. So if they're recommending it, I would recommend you ask them why. And if it met any of those criteria that I mentioned, it would be very wise to follow his his or her recommendations. As I mentioned before, we know for sure the lower the LDL, the lower your personal risk will be.
Right. Thank you. Here's another one. Thank you, Family Heart Foundation, for the amazing information. I had a stress test in the spring of 2025, which I failed, and carotid artery ultrasound in the neck as I had a pain in September 2025, which the ultrasound tech found something, but my cardiologist said it was nothing. I am seeing a preventive cardiologist tomorrow. Should I request these tests be done again?
I think the testing is accurate. I think what's missing is the conversation and the interpretation behind the results with the patient. So if you can ask for a copy of your results from all of your testing and take them to your visit, like especially if it's another doctor or another location, then you will understand it better. We also offer these services in care navigation for free. If a patient presents their testing to me, I cannot interpret tests. I cannot tell you I cannot read the test for you, but I can interpret with you in normal people language what your test results mean.
And that goes to the concept of scope of practice, correct? In terms of when you're looking at results and what you can offer in an explanation.
Well, scope of practice as far as our care navigation services, none of us, even though I'm a nurse practitioner, none of us are working in a clinical capacity where we can provide diagnosis or treatment or medical advice.
Right.
But we can navigate them through anything they've had done, anything they're going to do, help them to interpret results. If someone gives me a sheet of what their stress test was or what their echo result was, I can totally tell them what it means, but I can't be the one to say these are the results I'm giving you. This is just what your test results are showing. So that is something that we can be helpful with because I think one of the biggest issues I see with people that I talk with in care navigation is that they have many, many questions, but just did not have enough time with their provider to get an explanation of what anything meant. And so once they can have a sit down conversation with one of us, and we have 45-minute Zoom calls, often they extend to an hour, that's fine. But we can take our time to review your questions. And if we don't know and can't interpret them, we will help you write down a list of questions to give your provider.
Thank you. One other thing that's a little bit off that topic of Lp(a), but has to do with cholesterol is, can you address apolipoprotein B100 test and its purpose?
Sure. Oh, You guys, I don't mean to be answering all the questions. You guys want to go for it?
Sure.
No. You're saying no.
Yeah, no, because you were doing so well. I was like, wow, she's on a roll.
Well, what I like to explain about ApoB, yes, it's a very important marker. It's as important as LDL, yes. So, but what I need to help people focus on is they have to remember there's one ApoB for every LDL. So we choose one target, the LDL. And if your LDL comes down, your ApoB will come down. So I help people think about not chasing too many things because it gets confusing and overwhelming. Just chase the LDL because you can rest in comfort knowing that if your LDL comes to your goal level, your ApoB will be at its goal level.
Thank you. Okay, I'm trying to see if we missed any questions here because there always is something that I miss. Yeah. Yeah.
And if we don't get to a question tonight for some reason, please come find us in Care Navigation. You'll get all the time you need. We'll have one-on-one.
Right.
Hi
And then
guys, this is Jen. I saw a couple that I was just gonna point out.
Go ahead.
What is the best type of testing to know the level of soft plaque? Is it a CT angiogram?
The best test to know the soft level
Yes.
a plaque? Okay. So that's a tricky question because a CT angiogram is the initial test for soft plaque. However, this test is not recommended unless you're symptomatic. And that's because there are risks to this test. And there's also no indications for this test if you're not having symptoms. The reason we want to find out if you're having symptoms, we want to know if you need stents, right? So if you're not having any symptoms, you are never going to be a candidate for an invasive procedure like stents. So instead, what we rely on is very important for anyone, probably our whole audience or anyone at risk who's over the age of 38, 39, anyone at risk, high LDL, FH, high LPA, is to have a CT calcium score because that CT calcium score, which is a non-invasive 10-minute low-cost test, you can cover it out of pocket if it's not covered, will tell you how much calcified plaque you have in your arteries. Normal is 0, meaning no plaque. Anything above 0 is not normal, meaning, and it takes decades to develop that hard calcified plaque. If your calcium score is 0, you can rest assured that you have not been developing any soft plaque. If your calcium score is positive, and it can be as high as 1500, but if it's positive, even if it's 80, and you're not on treatment, and you have a high LDL and a high LPA, that means you're contributing soft plaque to your arteries and you need to get on it. So if you have a positive calcium score, that means talking to your provider about a statin to get your LDL at goal, knowing what your LPA is, reducing all of your other cardiac risk factors, blood pressure, smoking, A1C, blah, blah, blah. So if you get to the point where you're having chest pain with exertion, then that's a time CT angio would come in. And then you also have to remember CT angio, if you have no symptoms, can either cause symptoms or cause plaque to break off. So you don't want to cause a problem you don't have. CT calcium score does not do that. It's not invasive. So you want to wait until, well, the whole goal here with our whole foundation is not waiting for any of this. Our whole goal is preventing all of this. So hopefully you will never get to the point if we're catching all of you early enough that we don't want you to get those symptoms. We want you to know where you're at in your life with your risk factors today.
Thank you so much. I believe we've covered everything. Did we miss anybody? Jen, did you see anything that we missed? You're always good at finding those. One or two?
No, there are a few, but what I would recommend at this point is to call our Care Navigation Center and set up a one-on-one call with one of our care navigators. And let me take my video off. I'm sorry. And just you can have they can set up a call. You can ask questions for up to an hour. And it's free and you can call as many times as you'd like. And but that's what I would say for now. If people have more questions, we have the opportunity to provide for you some more resources. And Aurora has pointed out in the chat that you can go to our website and find lots of infographics and resources there and tools. We have past webinars that you can watch. We have some great ones with some experts on there that I think a lot of you would enjoy reading or listening to because they do answer a lot of these questions. And any other questions that aren't answered by Care Navigation, one of our care navigators, you're welcome to, reach out to your doctor too as well. I would definitely recommend asking them for the best medical advice. As again, as Anne said, we are not a clinic and we're not here to provide medical advice, just help guide you in the direction that would be most appropriate. So thank you, Susan.
Thank you, Jen, our Director of Community Outreach. And it's always wonderful to have you on the call with us. And again, I was
Thank
very, very grateful to the Care Navigation team. You're all spectacular. And thank you so much for doing a fabulous job for everyone out there.
Thank
So,
you, Susan, for hosting.
Thank you so
Susan. You
much.
did an awesome job.
You
good night,
did.
everyone.
Thank you, everyone.